First, thank you for staying back on a Sunday evening. I didn't even expect anybody, but you know, but yeah, it's there. Okay, cool. Yeah. So basically, we've been hearing a lot about AI. How human in the loop, how doctor has to be there. Everything. So uh, the I the two ways a physician can be in the loop. Okay, I'm going to talk about the other side, how they should be, and how it will make them easy for a larger fraternity of their fraternity. And this is extremely important. Otherwise, what happens is the human in the loop for the doctors will become a big burden. Instead of looking at one page, they're looking at 10 pages now. After 10, lot of things. It's going to be, huge work overload for them. So sometimes it's much easier directly dealing with things than going with AI. So this is extremely important. This is not something that's strange. They're doing this in the robotic space. They're doing this in the world in the world models. They're doing everywhere. I'm very surprised that nobody talked about in this conference, because the medical fraternity should be asking about this. They're doing this in the molecular space, the material science space. All the keynotes talked about it, except in the medical field. I was very surprised. So what's happening here is, there is this AI says I'm going to do preventive care, augmented care, diagnostic care, and running after healthcare, because that's a great application. That's a great application both in terms of the contribution that you can do as fellow humans, and also the value, right? There's huge value to it. But what's happening is, they're saying that you're trying all your models on me, all your AI innovations on me. So and we have to solve the problem. Fundamentally, the problem is, for an AI, you get 95%. If I'm building an AI model, I have an A grade. I'm wonderful. But for a physician, for the whole healthcare space, that's not enough. So fundamentally, the outcomes are different. What you're looking at is completely different. So now you're saying that, okay, go put a human in the loop so that I can figure it out there. So a human in the loop has to look at all these 95% as well. So it's not solving, it's very easy to say human in the loop, but fundamentally what has to happen is, the clinical knowledge has to go into the system. Okay, so what happens today, what is happening, just a recap of thing. AI, in general, people talk about AI. AI is not a monolithic thing. There's a huge thing. There's statistical methods, there's machine learning, there's deep learning. What it gave is perception, right? It gave vision perception, it gave audio, it gave speech, it gave text, right? So with that perception, we think we can be physicians, we can be something else, because I can see a X-ray now, I can see something else, So we're trying to pretend a lot of stuff, which is fine, right? Which is fine, but there's something else that has to happen. And that's the point of this talk. That's where neurosymbolic AI will come in. Okay, so these are good. They're good applications in the thing, but how do I make it less burden on how to make them better is what I want to say. So just don't read too much into this. So there is this whole lot of multimodal data coming in. There's a bunch of AI models, and then some predictions, deep predictions, right? So what exactly the middle box is doing for us is, it is doing pattern recognition. There is no reasoning why it's doing what it's doing. I'm identifying a tumor. How am I doing? I don't know. Nobody knows. And you're asking a human in the loop as a doctor to come in and say this and look at it, right? So and the people who build the models are gone, right? So, and then obviously hallucinations, we all know that, because it's all based on statistics, not on any other things. And then finally, failure in data. There is rare cases. The reason why that's important is, fundamentally, I'm an AI guy. Okay, so I'm a computer scientist for a long time, but I understand enough to humbly say, biology is not static. I don't even understand when people say that nobody talks about it. Whatever you train, biology is not static, right? So I'm sure, you all know more than me, and how metastasis happen, how things change, how cells shall behave, how they try to prevent themselves Even the wrong cells prevent themselves and multiply, right? So that's where the whole thing comes up. So whatever the best models you have today may be out in a few days, in a few years, right? So that's a problem. That's a black box problem. So essentially what it's saying is it's incredible at perception. So the deep learning can give incredible results at looking at things. Oh, this is a tumor. This is not a tumor. I'm finding latent parts of a tumor. I'm trying to see the contours of the tumor. I can draw it better for you. It can be incredibly good, but it is doing it by some other means. If the tumor actually has a different way of representing it, it doesn't know. And then models are ungrounded. There's no correlation. All it's looking at pixel and tokens. We all know that. There's nothing new here I'm saying. Okay? An alternative way that people build AI, which is the symbolic AI. The symbolic AI, what it does is, it actually understands the domain. That means it understands the clinical aspects, rather than the cell aspects, right? And then it says, okay, I'm going to build a rule-based engine, or I'm going to build a graph-based engine, based on the entire or ontology. So this ontology, this is how molecules behave, this is how cells behave, this is how protein structures behave. That's what I do, right? This is symbolic AI. So and this is based on this. So now the problem with symbolic AI is it's incapable of processing multimodal data. So it's very good because you painstakingly build the domain, you painstakingly build the graph, right? So it can understand that very well, but it cannot read an image. It doesn't have the perceptual capabilities of audio, video, text, kind of a thing, right? So that's why many people don't talk about this. But if you look at the keynotes, they're talking about the material science, all the innovations are actually happening because of symbolic AI. Because they're building these graphs on how different molecules, different chemicals behave, or different materials behave, and then they're generating from that. So now the bottleneck is for symbolic cases. And what is happening, I'm going to draw quickly a parallel as well, is you combine these two things. So you combine the neural, and then the symbolic. Okay, the neural layer is for your perception. The symbolic layer tells why it is. The domain, the clinical domain, the cell biology. It tells you the tumor, how a tumor changes. So you combine these two, then you get the neurosymbolic AI. And this has been done. They're doing this for other fields. I'm very surprised not many people talk about in this space. Okay, so and then that's where the physician comes into play. The physician comes into play because they understand if you're working with somebody who's building these models, you have to put your domain intelligence into that. B, if you're interpreting the results, then you should understand how the models are built. Is there any symbolic AI reasoning happening? So it's very easy for you to interpret the results and where things have gone wrong. Okay, so that combination can happen in multiple ways. The simplest way is you first do a perception based on that, and then you do some sort of rule-based verification. That means you're trying to classify a tumor, and then you say, okay, the tumor, according to these guidelines, the tumor has to be like this. If this is 3 millimeters, this is this, 5 millimeters, this is this, and I put a rules engine there, and that classifies. The perception is not classifying. You're not letting it learn the classification. You're letting the symbolic AI learn the classification because you can explain to the patient, or you can build a model that explains better, right? So that's the first one. Second one is you combine those two things, and then they interact with these two things. That means you kind of get some features by perception, because neural models are very good at perception. They see things. They see a blood vessel. They see hemorrhage. They see other things. So you pick those things, and then you say, okay, once these things happen, then I can identify, or I can predict something, and you put a symbolic reasoning there. And why the prediction? Why sepsis is going to happen, or whatever is going to happen? You can tell because it's coming from a symbolic layer. Just as a grounding thing. The third one is you can combine both of them. That means you create an entire ontology, and then the way you learn is in your loss function, you put both of them and let the system learn both of them. Then you can explain both of them, which is a little more complicated. Okay. So, for example, if you're doing this for a tumor, you can put the guidelines as a layer above symbolic layer. So let only the perception identify where the tumor is, what the diameter of the tumor is, Rest is coming from your symbolic layer. Okay, same thing with any protein, binding and other things. I'm going to go to one example. So basically, what this gives you is it gives you traceability, because the final thing that you're coming out is coming from your clinical domain knowledge, not from this black box. Okay, and then and if you obviously very rare, uncommon cases can be found because you're providing the domain knowledge on how a tumor behaves, or how any other disease, or this is not just I'm keep calling tumor, but any other disease you are interested in can be, you can code the domain logic, and that's where a physician is very, very important. Sometimes if they're interested in building the models, they're very important because they're equal partners. If they're using it, they should understand what is the domain knowledge that went into that. Okay, I'm just watching the time. So I'm not talking this, typically I don't give AA talks that many, because there's too many AA talks. Earlier, 10 years ago it was good, now because, and so this is something work that we have done. I have done, that's why I keep this, so that I'm not generally, giving anything. Here what we've done is, we're trying to classify retinoblastomy, right? And the physicians, the two physicians that worked with us, we worked with them. So they spent so much time with us. So one of the person that works with me, they call him like an expert. They call him like a fellow. He's an ML engineer. They call him because he can identify tumors like some of their fellows. That's the kind of domain knowledge we got from them, right? So what we do is, from the perception, we get a lot of features out, and then put a symbolic layer on top of it. So the doctors can explain when something is A, B, C, D, E. They can explain why it is D, why it's A. So when we presented this across, one of the top, in this field, in the Philadelphia, the field hospital, they sent us data. They never questioned the validity of the model. They asked the accuracy of the perception. The model is coming from completely medical knowledge, completely domain knowledge, right? So they never questioned that. So now, once they gave us, it's a different problem, because Caucasian eyes have different kind of fundus images. So we had to change the algorithm. All the red things we have to redo the red things. Remember, the perception, only the perception part we have to redo, because they have different fundus. So this kind of symbolic layer is what is needed for clinical decisions. I mean, there's a huge set of papers that I didn't want to go, but even for decisions, clinical decisions, this symbolic layer is going to help. It's about something. So I'm going to quickly go. They are actually doing this in the physical AI, in the world models. They're using physics. They're putting all the physics rules with the perception. So then when they take a video, when they take other things, when they take a task being done, they include the physics model in that on top of it. So that I'm moving this, a robot is moving this, it doesn't need to know what this is. It needs to know what it can hit, what happens, right? Same thing, I'm saying, the primary goal should be, the domain logic, everything has to come into play. This has to happen in the medical domain. That's my takeaway for this, okay? So the summary is, yes, deep learning gives you the eyes, but symbolic AI provides a clinical mind on top of it. And that clinical mind, A, you should provide it as a physician. B, if you're using it, you should understand what clinical mind goes into that, so that you can explain it to the patients, or you can correct it. Otherwise, it's a black box. You're just saying it's right or wrong. There's no way you can tell. It's wrong because of this, right? So basically, that's essentially the takeaway from it. And I think the time is up, so I'll just stop there.